The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So first of all, e ngā matawaka o te motu, tēnā koutou katoa, he mihi aroha ki ngā tangata moemoeā. So I'm a New Zealander, so I've got to prove we're more culturally aware than you guys, speaking in Māori. Thank you very much for having me here today. It's really nice to be able to come back to Australia for free. So that's a real bonus. So I'm going to talk a little bit briefly about the Health Quality and Safety Commission in New Zealand, because it differs from the Australian Commission in that it really has no role in accreditation or setting standards. And it operates really through influence and persuasion. We can't make anyone do anything. Though there are some levers available in terms of the indicators that are selected for reporting. So the various quality improvement programs have quality and safety markers that are reported nationally, usually using kind of nationally available data sets. One of the real benefits in New Zealand is that everybody has a unique national health identifier, which means that you can link data sets and figure out what is happening to people using multiple data sets. It's still complicated and there are still the same sorts of issues around coding, so it's very imperfect, but there are some useful opportunities for being able to measure the things that can help to force change. But essentially, in the work that I do, improvement work really relies on collaborative working relationships with the providers. The main providers that we work with, this is the obligatory map of New Zealand. I'm afraid I've completely failed to provide the obligatory slide of scenic New Zealand, so we'll have to make do with this instead. But essentially we have 20 district health boards, which are similar to local health networks or whatever, similarly sort of sized. And they provide free public health care and are funded centrally by the government. There are also some private providers, but their role differs significantly from Australian private providers. They really only provide elective surgical care the majority of the time. There are some specialist sort of mental health type things, but mostly the bulk of the work is elective surgical services. DHBs in New Zealand have very varying resources depending on the population that they serve and the services that are provided. Not every DHB has an intensive care unit, so when it comes to implementing recognition and response systems, we need to think slightly differently about how we operate, similarly to the work that needs to happen here in rural and remote areas. Hospital sizes in New Zealand really range from about 30 beds to about 800 beds. And most of the regions will have a tertiary ICU that they refer patients to if they don't have one on site. So there are lots of issues around transport and things that are similar to Australia, though obviously the distances are much smaller. So the Commission has funded a 5-year program with an investment of $2.5 million over that 5-year period to improve the care of patients who deteriorate in acute hospitals. There are some limitations to the scope, so theoretically it's only non-pregnant adult inpatients, though somehow I find myself currently involved in some work scoping deterioration in pregnant women and also in children, because I think those things are inevitable. There are some sort of significant work streams that are being tackled as part of this 5-year program, and again theoretically it's a sort of staged rollout of these different work streams, but inevitably where there is enthusiasm in the sector, for example with shared goals of care for patients at the end of life, we need to adjust project plans and look at focusing our attention on areas where people are ready to go, and I think shared goals of care at the end of life is one of those areas where there is significant frustration, I guess, from a clinical perspective that we're still not tackling the issues of managing people at the end of life very effectively. So I'm mostly going to talk about recognition and response systems today because that's the first year of work that we've just completed, and only briefly talk about the other work streams. So I guess the question is why the Commission invested in this patient safety program. From the Commission's perspective, $2.5 million is a pretty significant level of investment. We're small. And the real reason is that some enthusiastic clinicians, so Alex Sirides, who's talking this afternoon in particular, has made a case over the last number of years for the fact that there are real opportunities to improve our systems in New Zealand through standardisation of the tools that we use to identify deterioration in hospitals. The adverse events report that the Commission produces in 2015 showed really pretty clearly that there are continued failures of recognition and response systems in New Zealand, and these are likely really drastically underreported. And, you know, there's also clear evidence that there's considerable variation in the current systems in New Zealand hospitals. While there's been a lot of excellent work put in, and in theory all New Zealand hospitals have some form of recognition and response system, these have really been developed spontaneously in each DHB and implemented with really varying levels of effectiveness. They've largely been driven by really committed single clinicians who are trying to force change to happen without taking that sort of organisational approach. We've heard already a couple of times today about the crucial role of governance, and I think, you know, having been one of those clinicians who's trying to do this out of enthusiasm and commitment without any connection to the governance structures in the hospital, you just don't get to implement things very well if you're trying to do it alone. So this chart, I think, is a really good example of the problem that we're trying to fix. Alex and I have a collection of what we call chart porn, which shows us what the problem is from a clinical perspective. And I think this is a really good example because what you can see here is, you know, obviously the patient is a bit crook. So instead of doing something about it, we just switch methodologies for measuring how crook they are until they get out of the zone where I have to do something, or have a met call or die. And the charts that we use in New Zealand are all different. The processes that we use currently are all different. And there's considerable variation in the sort of vital sign triggers that are used for emergency calls, the clinical response that's provided, and the structures that support those systems. And we're small, so there's real opportunity for us to gain benefit not only for patients but also from a financial perspective by agreeing on what we do so that training can be provided once, and particularly at the undergraduate level. So this is the thing that we're asking people to implement. Obviously I worked at the Australian Commission on Safety and Quality for a long time in the Deteriorating Patient program, so I've lifted a bunch of their thinking because I figured it's mine too, you know. But essentially these are what we consider to be the kind of essential bits of the recognition and response system that we're asking DHBs to implement. And we've done some work with 6 early implementation sites, sort of testing out the tools and things that we're providing. And the 6 sites were really of varying sizes and settings. And what we found, obviously, is that there are some really significant challenges for people depending on the size and the setting of their hospital. I think there are some particularly problematic issues in terms of governance and resourcing. Obviously, the Commission is spending the $2.5 million largely on salaries and, you know, workshops and tools and things, not on providing direct resources to DHBs. That's not our role. So people are in the same boat as here, where you're having to do stuff with current resourcing, and that is a significant challenge. So, for example, at there was a small regional hospital that participated in the pilot work. There are about 150 beds and geographically fairly isolated, and they don't have any registrar-level staff. So in terms of forming their escalation pathway, there were some significant challenges there. And in the end, the senior medical officer group called in the union because they considered that having to formally respond to deteriorating patients after hours was a significant role change, which I found kind of interesting because I'm pretty sure that vital signs charts don't create sick patients. But in the end, you know, it paid off for the project officers who had been really struggling to try and get into the sort of executive and clinical leadership groups because the CEO then had to become involved. And the project team now have a pretty good grasp of how their organisation operates from a governance perspective. So these challenges are really difficult to overcome, but can have some additional benefits in the end. Turns out senior medical officers do have to respond to deteriorating patients if they're on call. So this is the chart that we're implementing. It's a sort of nationally standardised vital sign chart and early warning score, which is largely lifted from the UK National Early Warning Score, but with the addition of some single parameter triggers that indicate severe abnormality. It's pretty straightforward. It's no different from what people see every day. So people are asked to determine the escalation and response part of the system locally, given those issues with local resourcing and what is available. I think that there's some significant risk there because in many of our small hospitals, the rapid response team currently is a duty nurse manager and a house surgeon. And I have some serious doubts about their ability to manage really sick patients, which is the purpose of this work. So, I think we'll need to measure what happens very carefully and see if we are actually able to demonstrate any improvements in the care that these people receive. I think the benefit, though, is at least if they're referring to a bigger hospital nearby, they're talking the same language now, and that's going to help, certainly with the sort of efficiency of the process. So what we do is we give people this sort of information that says at this particular early warning score, this is the clinical risk, and it's up to your organisation really to decide what to do with that level of clinical risk. So in terms of measurement, apparently someone was telling me today that New Zealand's ahead of Australia in terms of measurement with MET data, which I find astonishing because we don't have any. Local data is generally stored on the single enthusiastic clinician's computer and is not reported within the organisation, certainly not reported externally. So a really big focus for us is looking at ways where we can measure what's happening better. We did some work looking at the national minimum data set and found that even cardiac arrest rates, we had worked with a hospital that had some good data about their cardiac arrest rates, and there was about a 40% match because of all the coding issues. So it's really difficult stuff to work on. So what we think that we're going to do is actually take an approach looking at variation, where we will measure lots and lots of different things using what data is available and also some locally collected data. And try and figure out what measures are actually feasible and tell us something useful over time. So the next work stream's patient, family and whānau escalation. So this is just slightly different approach to the approach that's commonly been taken here, where the Commission is supporting organisations through a co-design process, where consumers and clinicians will work together to design their systems. We're doing some work which I think could be quite interesting in a DHB that has a very high Māori population. Obviously in New Zealand we have the Treaty of Waitangi, which means that government organisations are obliged to take a bicultural approach to their work. So we'll be looking at developing a kind of Māori protocol for co-design work, which I think could be quite interesting, and we'll see what the differences are. I have a strong suspicion that we'll end up with 4 co-designed DHBs all coming up with a phone number for people to call when they're worried. But who knows? We hope to find some more effective ways to make sure that consumers can call for help if they need to. The other work stream I've already mentioned is around shared goals of care. We have the same issues in New Zealand. There was the few papers that do exist in New Zealand in terms of MET calls really correspond pretty strongly to the international evidence, where MET teams are spending about 20 or 30% of their time doing end-of-life care. So one of the things that I'm really keen to do is to shift the focus from making a better form to understanding how we can build this into workflow. I think one of the major barriers to doing this well is that everybody thinks it's somebody else's job, so find reasons to not do it. So I think we really need to be quite careful about how we approach this so that we're not just ticking a box saying we've got a new shiny form and are actually doing something useful. So in terms of the overall evaluation of the program, obviously the board want us to prove that we're saving money. I'm doubtful that we'll ever do that because of the issues of attribution and causality, but we'll give it a crack. And one of the things that we're really interested in doing is doing a bit of qualitative evaluation, particularly around culture change and safety culture, and also in terms of patient experiences of care. And that's that. There's a whole lot of stuff on the website, and Thank you very much.